My name is Jacob Kelly. I will be presenting our cross-sectional study in which we examine the correlation between periodontitis and dietary zinc in non-diabetic U.S. adults. Periodontitis is one of the most common chronic diseases worldwide, and it's estimated to affect more than 42% of the U.S. population. This occurs when opportunistic bacteria colonize the plaque and tartar within the gums, and that provides a protective environment in which they can receive nutrients and reproduce. They release virulent factors that inflame and degrade the surrounding tissue, and that causes bone resorption and a deepening of the pocket or the sulcus. That deeper sulcus is low in oxygen and is nutrient rich, and that provides an environment in which late colonizing anaerobic bacterial species thrive. They release more destructive factors, and that perpetuates the cycle. Over time, the bone and the gingiva surrounding the teeth withdraw. This exposes the anesthetic yellow root cementum layer and exposes dentin tubules, which can cause sensitivity of the teeth. Ultimately, this can lead to the total loss of teeth. Zinc is an essential mineral and cofactor in over 300 enzymatic reactions in the body, and is the most abundant intracellular trace element. Balance is key, and excess of zinc can have the effects of immune system suppression, diminish the absorption of other minerals, and decrease the presence of antioxidant enzymes. Conversely, deficiency can result in immunosuppression, impaired wound healing, osteoporosis, and an increase of reactive oxygen species, contributing to systemic inflammation. Zinc and periodontitis are linked in this way in their relationship to immune defense as well as systemic inflammation. And so zinc has been explored as a supplement and an adjunct inside periodontal treatment. Zinc and periodontitis are linked specifically by the role of MMPs. These proteins are secreted by immune cells to facilitate their passage into the site of infection or injury. MMPs break down collagen, degrading the tissue and allowing those immune cells to pass through. Zinc ions, when present in high concentrations, prevent the activation of MMPs, and in the case of zinc deficiency, leads to increased destruction of tissues due to overactivity of this enzyme. Therefore, low levels of zinc could theoretically lead to a faster progression of periodontal disease and a worse prognosis. So within our study, we decided we wanted to examine the data and see if there was correlation between a zinc-deficient diet and periodontitis while controlling for systemic, socioeconomic, and behavioral factors. And in our study, we chose to exclude participants that were pregnant and those with diabetes because of the association of periodontitis with those populations. We pulled our data from the National Health and Nutrition Examination Survey, or NHANES. Every year, around 5,000 adults and children are surveyed and examined in communities across the U.S. Medical exams, dental exams, medical lab tests, dietary interviews, and demographics are among the extensive data that's collected from these participants. The data is freely accessible to the public and is internationally recognized as a source for advancing medical research. Within the 2009 to 2014 NHANES cycles, the American Academy of Periodontology partnered with the CDC to develop an examination protocol for periodontal disease. The examiners measured probing depths and free gingival margins so clinical attachment loss could be calculated and periodontal disease diagnosed. We decided to use Ike's method in our study to maintain consistency with studies of a similar model. Within those same cycles, NHANES examiners administered a 24-hour dietary recall interview, in which participants reported all the food, drink, and supplements they consumed in the last 24 hours. That included a calculation of dietary zinc based on the responses to that interview. The RDA for zinc was developed by the Food and Nutrition Board at the National Academies of Sciences, Engineering, and Medicine, and that's what we used in order to report those who were deficient in zinc. After extracting and processing the data, we reported on the covariates we controlled for using chi-square tests. These covariates included age, race, sex, education, marital status, poverty to income ratio, BMI, insurance status, and smoking. We found the populations with the highest risk for periodontitis and zinc deficiency were male, Mexican American, non-Hispanic Black, those with less than 11th grade education, except those with some college had the highest risk for zinc deficiency. We're looking at you college students. Low income, except again, the middle income individuals had a higher risk of zinc deficiency, and those that never married. We also saw a higher risk of periodontitis in those who were overweight or obese, the uninsured, and in current smokers. However, zinc deficiency was prevalent most in the underweight and obese, and the uninsured and in current smokers. We identified correlation between the two using linear regression models. The unadjusted model number 1 saw a 23% increased risk for periodontitis in zinc-deficient populations. Adjusting for demographic, socioeconomic, and behavioral factors across our models, we ultimately saw a reduced but still significant 10% increased risk for periodontitis in zinc-deficient non-diabetic U.S. adults. In examining reasons for the patterns we saw in our covariates, we found some interesting insights from other authors. For older populations, a study reported that macrophages in aged individuals release higher amounts of inflammatory cytokines, which, in our mind, could contribute to the higher prevalence of periodontal disease in the older populations. In males, testosterone promotes the expression of pro-inflammatory cytokines, which could increase the inflammatory response and tissue destruction of periodontitis in male populations. Zinc deficiency in unmarried populations could be explained by an author's findings of increased consumption of fruits and vegetables, an accepted indication of diet quality to be higher in married populations. Another study identified that adipose tissues secrete inflammatory factors such as MMPs and cytokines, which would affect the prognosis of periodontitis in overweight individuals who have high amounts of this adipose tissue. Also in another study, nutrient-poor, calorie-dense diets are seen in those with obesity and could explain the zinc deficiency in these populations. A study of P. gingivalis prevalence, a noted pathogen in periodontitis, had higher levels reported in Hispanic and non-Hispanic Black populations. And another study identified these populations as having fewer socioeconomic resources needed to receive needed care. Lower education, lower income, as well as a lack of insurance were recognized in various studies as providing barriers to receiving care and meeting nutritional requirements. It is noted that foods highest in zinc, such as red meats and shellfish, are considered luxury food items and could be cost prohibitive. Smoking was seen in a study to cause oxidative stress and reduce circulation, which could contribute to progression of periodontitis, and another study found that diets of lower quality were seen among smokers compared to non-smokers. In conclusion, we were able to identify a significant correlation between dietary zinc and the risk for periodontitis. Diet quality, especially relating to zinc sufficiency, should be investigated further as an adjunct to treating periodontal disease. We, as the author, suggest that additional education and research in nutrition should be explored within the dental profession, as it could prove to be beneficial in enhancing patient oral health outcomes. We would like to note that our findings were only significant within the limitations of our study. Periodontal values may be subject to underdiagnosis within the data because NHANES examiners rounded down in their probing depths. And our zinc data was collected via interviews based on dietary intake in the last 24 hours, which is subject to recall bias and the fact that the 24-hour period may not reflect the individual's usual diet. Only the U.S. population was measured in NHANES data and cannot be generalized to other populations. And of course, due to the fact that our study is cross-sectional, we can only identify correlation between zinc deficiency and periodontitis and not causation. Thank you for your attention during the presentation of our research today.